Hello, and welcome to the Alabama Public Health Training Network. The Alabama Newborn Screening Program currently tests for 30 primary disorders, with hearing loss being the most prevalent. Today, we will learn more about the process used to detect hearing loss in newborns. We will also discuss the ADPH Care Coordination Protocol related to newborn hearing referrals. And we will also discuss the significant changes made to the Report to Referring Provider section in the ACORN documentation system. Thank you for joining us today for our program, Alabama Newborn Screening Program, Early Hearing Detection and Intervention. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 2 years, expiring on July 31st, 2018. If you are watching this program on demand and want to receive a Social Work CE certificate, then you will need to complete the Social Work test and send it in, along with your sign-in sheet and evaluation. If you are watching this program live, there is no Social Work test required. I'm Meredith Adams, Director of Social Work for the Bureau of Family Health Services at the Alabama Department of Public Health. And joining me today, we have Melissa Godwin, who is our DHR EHS Grant Coordinator for the Bureau of Family Health Services, and Suresha Johnson, a Nurse Educator for the Newborn Screening Program, and Mary Ellen Wingham, Hearing Coordinator for the Newborn Screening Program. Welcome, everyone, and I just wanted to say how I'm super excited about having y'all here today. Yesterday, I got an email from a manager that had a question about the newborn hearing protocol. So I just wanted to double check it, and so I emailed Suresha and talked to Suresha yesterday about a question in protocol, and I'm super excited that we're doing this today because she clarified some things for me yesterday, which could possibly entail a protocol change at some point. But so I'm glad that Suresha is going to go over some interesting information about the newborn hearing program so that we can kind of learn a little bit better about what our roles and responsibilities are with that and understand the background to that. So I'm going to turn it over to Suresha so we can get started. So thank you, Suresha, for joining us today.
Of course. So good morning. As Meredith said, my name is Suresha Johnson. I am the Nurse Educator with the Newborn Screening Program. And today, after a brief overview of the current newborn screening conditions, we're going to discuss appropriate newborn hearing follow-up procedures, and at the conclusion of the program, we'll introduce our new Hearing Program Coordinator, Mary Ellen Wingham. So approximately 50 years ago, the Alabama Newborn Screening Program began testing for phenylketonuria, or PKU. Today, we screen for 30 primary disorders as well as many secondary ones. Among those, we have 3 primary hemoglobin disorders: sickle cell disease, sickle cell C disease, and beta thalassemia. We have cystic fibrosis with varying clinical presentations dependent upon the mutations that a baby inherits. 2 primary endocrine disorders, congenital hypothyroidism and congenital adrenal hyperplasia, and 22 primary metabolic disorders, which includes galactosemia and phenylketonuria, all of which are completed from the blood collected on filter paper and transported to the Bureau of Clinical Laboratories for analysis. Hearing loss is initially detected through hearing screening completed at the birthing hospital, as well as critical congenital heart disease, which is detected through a pulse ox screening done at the hospital as well. While you may receive a referral for any one of these disorders, today's focus, as Meredith said, will be on the hearing follow-up.
And Suresha, I just wanted to ask you real quick, the sickle cell disorder and those types of things, when you mentioned filter paper, that's that heel stick that they do, and they put the blood spots on it. Is that correct?
It is. They put 5 drops of blood, and it dries, and it's sent to the state lab, and that is what they use to run all of these tests.
And sometimes it could be that maybe the blood spot wasn't within those little lines, and so they'd have to do a repeat of that. And sometimes that occurs as well.
That we do sometimes have issues with the specimens that are sent in, not necessarily being out of lines, but one of the major issues we deal with are uneven saturation, and it just has to do with a concern of even analyte concentration throughout the spot of blood.
Okay.
And so they do want to make sure that they're getting accurate results at the state lab when they run that.
And the congenital heart one, the pulse ox that you mentioned, that's the little thing that they put on their finger.
It is, correct.
Okay.
It's the little, they wrap it, they do a hand and a foot, and they're looking at the comparison in the pulse oximetry, which measures the oxygen saturation.
Okay.
To determine that.
Thank you for clearing that up for me.
Of course.
Thank you.
Of course. So among the newborn screening conditions, hearing loss is considered the most commonly occurring disorder, with 1 to 3 out of 1,000 infants having hearing loss. For us here in Alabama, that could mean as many as 170 infants could be born with hearing loss in any given year. Prior to universal newborn hearing screening, the average age of hearing diagnosis was 2 years of age. However, research has clearly shown us that an infant with hearing loss should receive appropriate early intervention services by 6 months of age. This is significant because we do frequently, or at least occasionally, receive parent calls regarding a child that was not diagnosed until after 2 years of age. So you often have a child that's now struggling academically or socially because they have a hearing loss that was not identified and addressed in the appropriate time frame and manner. So timeliness is very, very important when it comes to diagnosing hearing loss. Another complicating issue is late onset hearing loss, which can occur even after an infant has passed the initial hearing screen. For this reason, it is very, very important that every infant be monitored by both the parents and the primary care provider for any developmental delays that could indicate hearing loss. In addition, infants with known risk factors should receive a complete audiological diagnostic evaluation by 24 to 30 months of age, even in the absence of developmental delays, although certain risk factors may require earlier or more frequent assessment and evaluation. So what is EDI? EDI refers to the Early Hearing Detection and Intervention Act that was enacted by Congress in the year 2000 to provide funding for universal newborn hearing programs nationwide. Alabama's Listening is the EDI program for the Alabama Department of Public Health. Initiated in 2001, we ensure that all Alabama birthing facilities are able to screen for newborn hearing loss. However, universal newborn hearing screening was not a mandated part of the newborn screening panel of disorders until 2008. And of course, here in Alabama, like anywhere, the goal of our program is to ensure early identification, treatment, and intervention for infants with hearing loss. According to the Joint Commission on Infant Hearing 2007 position statement, Principles and Guidelines for Early Hearing Detection and Intervention Programs, the goal of EDI is to maximize linguistic competence and literacy development for children who are deaf or hard of hearing. And this can be accomplished by simply following the 136 plan outlined in the Joint Commission position statement. So what is the 136 plan? We know that the quicker we identify a baby with hearing loss, the better the outcome is going to be. So the 136 plan outlines the recommended time frames to accomplish specific steps in the diagnosis and intervention for hearing loss. First, a hearing screen should be completed by 1 month of age. For most infants, this means up to 2 hearing screens completed in the hospital and an additional outpatient screen following discharge while the infant is still less than 1 month of age. Secondly, an infant that does not pass their hearing screen should receive a comprehensive audiological diagnostic evaluation by 3 months of age. This may require a series of appointments and a variety of tests to confirm their hearing status. And thirdly, if an infant is found to have hearing loss, they should be enrolled in an early intervention program by 6 months of age. This provides the best opportunity to ensure that every child develops communication and social skills commensurate with their cognitive abilities, or to put it simply, ensures that every child has the chance to reach their full potential. So as I said, by 1 month of age, an infant should have received at least 1 hearing screen. However, under certain circumstances, such as an infant in an neonatal intensive care setting, this may be delayed. In Alabama, we receive the hospital hearing results through a secure file transfer protocol, or FTP, process, which ensures we receive the results no matter how delayed the testing, as long as the hospital follows the correct FTP procedure and sends hearing results to us no less than 3 times per week. It is important that hospitals complete no more than 2 inpatient hearing screens on an infant and schedule any infant that does not pass an additional outpatient screen before 1 month of age. It is also important that regardless of the previous result, both ears should be tested every time a baby is screened or tested. The role of the care coordinator at this point is to ensure follow-up testing is scheduled and completed. It may be helpful to contact the hospital and verify that you have received accurate results, since not every hospital sends us results in a timely manner. To clarify, an infant could receive a hearing screen and not pass, and then pass the second screen before discharge. The hospital may have sent the initial hearing test, but not sent the follow-up result. So we're still sitting here with a non-passing result on the baby, which is what is forwarded to you. The care coordinator should also ensure that appropriate testing is completed. This includes knowing that the correct test method is used and that both ears are screened each time. A care coordinator may need to provide guidance to an office that wants to complete multiple screens, instructing them that diagnostic testing is the next appropriate step, as opposed to waiting another month and completing an additional screening test. Lastly, the most recent results should be forwarded to the newborn screening program and should include the date and method of the test, as well as a result for each ear. It is also helpful to report any follow-up testing that is scheduled if indicated. Anytime you're able to obtain written documentation of the results, please forward those to the newborn screening program as well.
And I would just like to say, just to remind everyone, we haven't made a change to the protocol in regard to forwarding that information to the office, but what we were discussing with newborn screening last week was that it would just be really great for newborn screening if they had those results. So if you do actually get the written copy, if you would please fax those into newborn screening. But again, there's not been a protocol change at this point. Sorry to interrupt.
That's all right. Thank you. By 3 months of age, we want an infant to have received that audiological evaluation if any type of hearing loss is suspected and they have not passed that repeat screen. However, there may be some circumstances that warrant different actions. For example, an infant may be sent to their primary care provider for diagnosis and treatment of an ear infection, followed by additional testing, which may be an additional screen or diagnostic testing. Or they may be referred to an ENT or otolaryngologist for diagnosis and treatment of ear effusion or fluid on the eardrum. If surgical intervention is warranted, then they may even complete additional testing in the operating room after the surgery is completed and the fluid has been cleared. However, typically, after an infant does not pass an outpatient hearing screen, they should receive a complete audiological evaluation, which may include a variety of testing methods to help determine the type and severity of hearing loss present. One such test is the tympanogram, which does not test hearing, but instead evaluates the function of the tympanic membrane, or the eardrum, and helps to determine what testing or treatment should occur next. At this point, the care coordinator should be providing care and guidance to both the family and the primary care provider. By continuing to ensure follow-up testing meets the national recommendations, each infant can receive appropriate and timely intervention. Again, when reporting results, please provide a date and a method, as well as the results for each ear. If this includes a preliminary or confirmed diagnosis, you should also report the type of hearing loss and the severity for each ear. As with the hearing screen results, please fax written documentation anytime that you are able to obtain it. And then most importantly, and ultimately our end goal, is that for any baby with hearing loss to be enrolled in early intervention by 6 months of age. This process will be different for each family, as some may choose hearing aids in spoken language, while others may choose American Sign Language or some other form of nonverbal communication. The type and severity of hearing loss will also determine the early intervention options that are available to each individual infant. The important thing here is that the early intervention program that a family is referred to needs to be one that can meet that family and that infant's individual needs. The care coordinator role is to ensure that the infant is enrolled in early intervention by that 6 month of age mark. In Alabama, infants may receive early intervention services through Children's Rehabilitation Services, the Alabama Institute for the Deaf and Blind, Children's Hospital of Alabama, Huntsville Hospital Pediatric Therapy and Audiology, or another local agency with the appropriate services to meet the infant's individual needs. If you find at the time of the referral that the baby is not eligible for early intervention services, it is important for the care coordinator to continue to follow that infant, provide that support and those resources until the infant is either determined to have normal hearing or the baby has been diagnosed with hearing loss and becomes eligible and enrolled in the early intervention program. So now that we have discussed the overall process for EDI, I'm going to cover some of the steps more in detail. As we've already discussed, every infant should receive a hearing screen by 1 month of age. This is a non-invasive automated test designed to detect potential hearing loss. Because it is just a screen, it cannot determine the type or severity of hearing loss, but what it does determine is whether the hearing organ is functioning within normal limits at the time of the test and reports those results as either a pass or a refer. A hearing screen does not require sedation if it's completed in the appropriate time frame. Therefore, it is important that this step is not delayed. An older, more active infant can make testing much more difficult and can cause a delay in the diagnosis and intervention. There are 2 types of hearing screens currently available. The autoacoustic emissions, or OAE, is a hearing test that tests the hair cell function of the inner ear. Soft clicks or tones are presented into the infant's ear through a probe snugly placed in the entrance of the ear canal. A small microphone in the probe measures the echo that returns from the infant's ear. The OA equipment then analyzes the echo and determines how well the inner ear is working. This is the more basic of the hearing screen methods and can be completed on infants, children, and adults. However, the automated auditory brainstem response, or AABR, is the more complex hearing screen method. It screens both the ear and the auditory nerve. A soft click is presented to each ear while electrodes placed on the infant's forehead, neck, and shoulder record the responses as it travels between the ear and the brain. The response is analyzed to determine how well the inner ear and auditory nerve are working. This method is more difficult to perform on older infants and is not an appropriate test to complete after 6 months of age. It is important to differentiate between an automated auditory brainstem response, the AABR, and the diagnostic auditory brainstem response, or ABR. The ABR, rather than being an automatic passive refer result, is a diagnostic test that a professional, such as an audiologist, would have to read the results and determine what hearing loss is present, if any, from that readout. The diagnostic ABR can be done past 6 months of age. However, again, when you get past 6 months, they do sometimes have to do sedation to be able to actually do that test. And you do see some alternate methods used on older infants. And this next slide just illustrates the difference in testing between the OAE and the AABR. Because the AABR is more comprehensive, it can detect a form of hearing loss called auditory neuropathy spectrum disorder, or auditory dysynchrony, another name for it, whereas the OAE cannot. Therefore, it is important that once an infant refers an AABR, they should not receive an OAE as the final test or screen to determine normal hearing. So just as far as determining appropriate screening method, it's very important you know some of the key factors so that each infant receives the appropriate test for whatever their circumstances may be. An OAE is the appropriate screening method for any well baby with no known risk factors. However, as I've previously stated, it should not be used as a follow-up screen after a refer AABR result has been received, since a diagnosis of auditory neuropathy could be missed. For an infant with any risk factors, including a NICU admission of more than 5 days, AABR is the only screening method that should be used. And I'm just going to go through, there are numerous risk factors that could lead to hearing loss, either now or late onset. So I'm just going to read through these really quick. One of the first ones you may get may be the family history or that NICU stay of more than 5 days. A lot of babies in NICU, they may receive ototoxic medications such as gentamicin or have hyperbilirubinemia that requires special treatments. Certain in utero infections such as cytomegalovirus or CMV and craniofacial anomalies are also other risk factors that could predispose a baby to hearing loss. If a baby has a syndrome or physical findings associated with a syndrome, which is known to include permanent hearing loss, that would be another instance that you would be more sensitive to looking for that hearing loss. Also, neurodegenerative disorders, postnatal infections associated with sensorineural hearing loss, head trauma, and chemotherapy.
So let me ask you, so when we are, the care coordinator is working with the family and the family is saying, may give some information that includes the child has one of these risk factors, then it would be appropriate or helpful information for newborn screening in the report to referring provider, that this information be included in that additional information section for you guys?
Oh, absolutely, absolutely. We actually have a letter that goes out at 18 months of age on any babies that we know have risk factors, and it's just a reminder letter to the parent that says, we know that your baby passed the test, but it's recommended that additional testing be done, and it just talks about doing that diagnostic evaluation by 24, 30 months of age. So absolutely, that is definitely a pertinent piece of information. And for your information too, these next 4 slides actually show an insert that we put in those 18-month letters. While these are not available online, we do have them, and if you wanted to have some of these on hand for yourself, you could contact our program and get those as well. So let's talk about hearing loss diagnosis. There are 3 types of hearing loss that may be present: sensorineural hearing loss, conductive hearing loss, and auditory neuropathy spectrum disorder. An infant can also have a mixed hearing loss, meaning they have some combination of these types of hearing loss. In addition to the type of hearing loss is also reported by severity. And while this slide indicates 4 primary designations, hearing loss is often reported as a range. For example, you may receive a report that says a baby has mild to moderate sensorineural hearing loss in their left ear. So all of that is helpful to us. We want exactly what they say for that baby's hearing. Specifically, sensorineural hearing loss is the most common type of hearing loss and is caused by damage to the cochlear or the auditory nerve pathways. This will reduce the ability to hear faint sounds and usually cannot be surgically or medically corrected. And this is very, very important. I cannot say this enough. Even when speech is loud enough to hear, it may be unclear or muffled. And the reason that I really, really stress that for you care coordinators is because I have had many a mother tell me that their baby does not need follow-up hearing testing for the simple fact that their baby startles at sounds. But a baby startling at sounds is not a clear indicator that there is not hearing loss. It is important to educate families about this aspect of hearing loss in hopes that they will do the appropriate follow-up testing for their infant. Common causes of sensorineural hearing loss are heredity, malformation of the inner ear, ototoxic medications, and certain illnesses. Although not as common in infants, it can also be caused by aging, head trauma, and exposure to loud noise. The last is also particularly important because when educating a parent whose child has been identified with a unilateral hearing loss, meaning they have hearing loss in one ear, frequently the recommendations the audiologist gives them is to ensure that the infant is not exposed to loud noises, because at that point they are trying to protect the hearing in the ear that has normal hearing. So it's really important they understand that, because that gives that baby the best opportunity to be able to learn that speech and language as they get older. Conductive hearing loss is caused by inefficient conduction from the outer ear to the middle ear. This results in reduced sound levels, but can often be medically or surgically corrected. Causes of conductive hearing loss include the absence or malformation of the outer ear, ear canal, or inner ear, the presence of infection or fluid, poor eustachian tube function, a perforated eardrum, or a blockage of the ear pathway by earwax, a tumor, or some type of foreign body. Maybe something the child stuck in there themselves. Specifically, the absence or malformation of the outer ear is called microtia, and the absence of the ear canal is called atresia. So when you receive reports, you may see one of these terms on there. And just know that part of the reason that baby is not hearing, at least part of it, is because there is actual blockage in the conduction of sound. These conditions can be surgically corrected, but typically are not corrected until school age. And these photos here actually show one child and demonstrate the progress that is made. When it is an issue of microtia or atresia, it's usually multiple procedures that they get that child to a point that they actually have an open ear canal and or a normal ear formed. So it just kind of gives you the picture of that.
So, Rachel, are most of these procedures done at Children's or throughout the state, or is there
most of the ones I have dealt with are through Children's, but I'm not going to tell you that they don't do them elsewhere, because I'm sure there are other places that do them. It's that Children's, because of all the specialties there, sees a lot of these babies and does these.
And when with conductive hearing loss, is that if there's a procedure that needs to be done, is that typically done when they're in the early intervention stage, when they're actually typically with the early intervention services, or is that sometimes done on the front end before we would actually be referring the case to early intervention?
Typically with conductive hearing loss, you would be referring to early intervention, and they would be receiving those services for that conductive hearing loss until it could be corrected. And just very briefly, the issue with this type of conductive hearing loss, where it is actually a malformation of the ear, is the child has to be big enough, that they can actually have the tissue to graft and create that ear. So that is why there is a delay in this particular type of procedure. So they should definitely be receiving early intervention services well before this procedure is done. So the third type of hearing loss is auditory neuropathy spectrum disorder, or auditory dysynchrony, and it is caused by an inconsistent or dysynchronous signal from the eighth nerve to the brain. Unlike other types of hearing loss, the auditory neuropathy doesn't have really a set pattern that it follows, so there is no way to predict the progression or best treatment from one infant to the next. In a previously undiagnosed infant, auditory neuropathy should be suspected if you have an abnormal ABR or AABR result with normal OAEs present. If you have a baby or a child that has been diagnosed, they've got a good high-quality hearing aid, and they have some residual hearing so that should function, but they are still not progressing in speech and language, that may be another instance that additional evaluation would need to be made to ensure that that's not auditory neuropathy as well. And that just has to do with, again, the inconsistency of the signals what they're getting with that particular type of hearing loss. So that is all on the hearing procedure. For more information, you can contact the Alabama Newborn Screening Program. You can contact us to order the risk factor and the developmental milestones card. We also have this brochure for hearing that's available on our website. It can be ordered directly off our website free of charge. If you find these would be useful to have on hand for families when you meet with them.
I would like to comment on Newborn Screening's website. They have some great information, some fantastic links for any of the metabolic disorders, including hearing, and some great handouts for the patients and their families. So I would just encourage anyone that's working with these families to go there, because it's up-to-date information, it's resources in our state, it's just extremely helpful. So I would just definitely encourage our staff to refer to that page.
Yes, thank you.
One of the things that we see a lot of is the correct screening being conducted in our records. So I want to go back over that real quick just to make sure that we know that we're all on the same page. So if an infant has an OAE in the hospital, then when they don't pass it, they have a rescreen, they can have an OAE again.
That is correct.
Okay. If in the hospital they have an AABR, they can only be rescreened with another AABR.
That is correct. Once they have failed that AABR, then they are automatically presumed to be at risk for the auditory neuropathy. Therefore, you don't want to do any screening that could not detect for that.
Because from the picture that we saw, the OAE only goes so far.
Correct.
But the AABR goes all the way.
Yes.
And we can't go backwards because the problem could be between the OAE and the AABR. So that's why you want to make sure that you use the same type of screening method.
Absolutely.
That was
yes.
used. Okay. And the other thing that I've learned is that the ABR is a diagnostic test that's done after the AABR.
Correct. That is typically part of the diagnostic evaluation. Like I said, it may be part of a series of tests that are done. Sometimes they may even include the OAE in diagnostic testing. But again, that's differentiating, like we talked about with the auditory neuropathy. If you have OAEs present but your ABR is abnormal, then you would be very suspicious that it's auditory neuropathy. But yes, so the ABR, the diagnostic ABR, and I will say, even for me, I still, if I'm getting results, I always differentiate, was this automated or was this diagnostic, when they give me an ABR result, to ensure that I'm documenting the correct information for the result that they're giving me. Because sometimes they just say ABR and it can be a little unclear if they mean automated or diagnostic. But yes, so that ABR, that diagnostic ABR, is typically part of the diagnostic testing that is done after that last failed screen.
That is quite confusing.
Yes.
Yeah, because I know in protocol it talks about that, and then it switches between AABR and ABR. I'm like, what's the difference? So I'm much clearer now that the AABR happens in the hospital before the patient, the infant is released, and
right.
before 6 months of age. Because after 6 months of age, the infant has to go under sedation.
Well,
sometime.
Well, with the AABR, because it's automated and because of the very rapid brain development with infants, they just don't do the AABR after 6 months of age.
Okay.
If you have a baby that you don't get in for a screening before 6 months of age, there are alternate methods they will use. They may combine an OAE with a behavioral test, where they may put a baby in a sound booth and look at how well they respond to the sounds. And those babies typically require more follow-up, just in the fact that they may need to be a little older before you really can assess how well they understand sound versus hearing sound. And so it does complicate the process a little bit if those babies aren't getting in there early enough that we can get accurate screening results on them the first time.
Can they do an AABR like at 1 month of age if they've got an ear infection?
They can, but the ear infection may very well give them a refer result and require additional follow-up.
Okay, and the diagnostic follow-up testing, do they have to be clear of ear infections for that to be conclusive as well?
Typically.
Okay.
And that's where the tympanogram comes in. A lot of times an audiologist or an ENT may do the tympanogram first. And if they don't get normal results with the tympanogram, they may not even do a hearing test until after the baby has received medical follow-up for that issue first.
Okay, so let's say that the infant failed the newborn screen in the hospital and it was an AABR, and then they're set up to go back in for a repeat AABR. We've got an ear infection.
Right.
So they can't get it done. Then we've got transportation problems and we miss a couple appointments. Then we've got another one scheduled. They've got another ear infection again. Well, now they're 7 months old and they had an AABR in the hospital. So what do we do in that situation?
That is where the audiologist or ENT, whoever actually sees that baby, would make the professional judgment of what test would be appropriate. And again, that's where you may get into a combination of doing an OAE and then putting them in a sound booth to see how they respond to sound, and then continuing to follow that baby until they're old enough to do a more conclusive behavioral test.
Okay.
Because I don't work that side, I can't tell you every angle they may look at, but that is typically what I see is the OAE with the behavioral test, or sometimes just the OAE, and then they decide to come back and do the behavioral test when the baby gets a little bit older.
So to make the care coordinator's life easier, the best case scenario is if they did not pass an AABR in the hospital, to try to get that AABR conducted before they turn 6 months of age.
Yes, and ideally before 1 month, but I know that that's not always the way it works out. So
that can be quite a challenge. So, so do all ENT offices in general have an AABR option, or is it mainly just OAE?
It really varies throughout the state, and the best thing to ask before a baby goes in for an appointment may be to touch base with the office and make sure if you're needing an AABR that they can offer that, and maybe even save that family a trip to that office if they need to be seen somewhere else for that test.
Because logic is telling me that a primary medical provider, just your regular family doctor, most likely wouldn't have the AABR equipment.
Correct.
Yeah, they could have an OAE, but the odds of them all having AABR, I think, would be challenging. So they probably need to go ahead and be set up with an ENT at that point, because they're more likely to have that equipment. And the care coordinator would want to make sure that the provider the child's going to has the AABR before they send them. So, okay.
Absolutely.
All right.
So Rachel, let me ask you this. So you have a care coordinator, and they're very knowledgeable of the process for the hearing screening and diagnostic testing. And they're working with a local provider, and this doctor's office, you don't want to make them mad, I guess is the term. And you don't want, but you really don't think the doctor's office is quite up to par with the way that it should be done. So are you available for the care coordinator, or someone in your office available for the care coordinator to call and have a conversation, or how would you handle that kind of situation? Do you make contact with the provider's office, or what?
I have before. I have never had a problem, and I know that Mary Ellen would not have a problem either if we had an office that had questions and wanted to contact us directly. That we're more than glad to have our information shared and let them contact us and answer those questions for them. So we're available for any questions regarding correct method and the next step in the process, and absolutely.
Well, again, if you have questions, you can call or email us while we're here live today. And just one more time, OAE, you can do another OAE. Right. But if it's an AABR, you can't go backwards and do an OAE.
Correct.
We see that a lot in our case management records, so we just wanted to make sure that we've got that down pretty good. And the ABR is a diagnostic that can be done later on.
Correct.
Okay. All right.
I think we were going to take a break, and then I know everybody's excited about learning about the new format with ACORN, so because I know we're excited about it, but I think we're going to take just a 10-minute break and then come back and talk about the changes in ACORN.
and welcome back. I wanted to give Rachel Montgomery an opportunity to tell us a couple of things about the newborn screening program as well. She is the director of our newborn screening program. So, Rachel, thank you for joining us today.
Thank you, Meredith. I just wanted to reiterate what Melissa had previously stated about our website. We do have resources available on our website. We have a hearing page with hearing resources and links. And we do have a directory that we provide for families with a listing of outpatient screening, audiology screening providers in our state. We do try to list the method of screening that they use. So that's a helpful tool, resource for the care coordinators and for the families when and our providers too. And we keep that updated on our website.
Okay, great. And Rachel, I want to thank you also. I know I asked you lots of questions too as well. So Rachel is a great resource for us as well. So sometimes when we get questions from out there in the field, I'll call or email Rachel. And, you know, we all work on the same floor. So if ever y'all have questions, it's real easy for us to go and try to get the best answer possible for you. And speaking of questions, we've had one to come in. If you have a baby that failed the AABR in the hospital and has had several ear infections and couldn't get a good AABR reading, and then the baby ends up being over 6 months old, and the ENT chooses to just do an OAE and complete the behavior test when the baby is older, do we, as the care coordinator, just take the OAE results and close? Or do we keep it open because the ENT could choose to complete a behavior test 6 months or a year from now? So we're just not clear on what we need to do if the ENT chooses to not do the AABR because of the baby's age, and how long should the care coordinator continue to follow based upon the ENT's decision?
Okay. Well, I mean, it kind of ties back in with what I was saying earlier. So we know the baby, we really wanted baby to have a good AABR before 6 months of age. We had issues that interfered with that. So obviously after 6 months of age, we do not want them doing an AABR. We don't expect accurate results. But what will need to happen is that while, yes, we will take that pass OAE result and close the case, and the care coordinator can do the same, it is an opportunity to educate the physician, the audiologist, whoever you may be speaking with, to make sure that they, you know, are following up, that importance of following up and getting more conclusive information later when the baby is older. And that goes back to the monitoring for those developmental delays that could show up and indicate hearing loss even before the baby is old enough to necessarily do all the testing. And that may be a time that they would look at a diagnostic ABR when they could potentially sedate the baby if they strongly suspected hearing loss. So there's a lot of different things you can do with that, but the main thing is that, yes, once we have a passing OAE, even if the baby had an AABR in the hospital, we would close that case. If the baby happens to be before or younger than 6 months of age, there's a letter in the protocol that can be sent out that just reminds the doctor that, hey, this baby really needs to get an AABR test.
So if the infant is past 6 months of age and the ENT has chosen to wait to do that behavioral testing, but they had a passing on an OAE, and the worker is going to go ahead and close out that case, it's going to need to be documented in the progress notes that due to the infant being over the age of 6 months that an AABR is not feasible at this time. The ENT has chosen that the infant has passed an OAE, and we can also, if we need to, discuss that with newborn screening just to make sure that we're okay in closing that out. But like Saracia said, if they're closing out the case, then we can go ahead and close that case out as well. But the care coordinator will need to document the infant's age in the progress note just to make sure that that's clear.
And I'd like to piggyback on something Meredith just said. Also, we don't typically recommend cutting and pasting from progress notes to the report to referring provider. But in this situation, I think what the note that Meredith had just said, that'd be very appropriate for you to copy and paste into the additional comment section of the report to referring provider, just to call attention to it for newborn screening.
So thank you for your question, and again, please do not hesitate to call or email us while we're on live this morning. But right now, we're going to go ahead and turn the program over to Mary Ellen Wiggum, and I'm excited to hear about her story because I don't know about you, but with training, I learn a lot better when I hear personal stories. So I take more information from that and seem to learn better from that. So I'm super excited to hear about Mary Ellen's story. So we'll turn it over to you, Mary Ellen.
Thank you. We appreciate the opportunity. Being the new coordinator for newborn screening hearing, I have personal experience. My child, unfortunately, was born before the Congress enacted mandatory testing, so therefore we did not have that opportunity. My son was diagnosed at 8 years of age with conductive hearing loss. We wore hearing aids, and but unfortunately, we had so many risk factors that we didn't know about it until after I started studying and learning. Being a nurse, there was still a lot I needed to know. And he was premature 4 weeks, had a low APGAR score, and therefore had lots of oxygen, and had lots of ear infections, and had tubes by 6 months of age. And then, you know, he had a sister who was right ahead of him by 14 months, so, you know, she was a little bossy mama. And so she took over and she did everything for him, and, you know, it was okay. He said dada, mama, and dog, and, you know, that was the extent of his vocabulary for a long time. But they were very clear. There was no deficits in his speech, and so we just kept trucking along as a family and had a couple behavior issues in preschool. You know, getting along with others and stuff, but, you know, the teachers kept going ADD, ADHD, and I'm like, no, I just don't see that at home. And so then we kept struggling with school. We moved when he was 5, so God love him, who knows how he was adjusting, and so we just kept going and doing, and by the time we had to repeat first grade, we needed glasses, so we thought, there's our problem. Second grade came along, and it was like, he's still not progressing academically, and so they wanted to do ADA testing, ADHD, and I'm like, no, let's go check his hearing, because by that time I got knowledgeable. And so we went and saw the ENT, had it tested and checked into it, and sure enough, Caleb had mild to moderate hearing loss. And so we went through the adjustment of hearing aids, and, you know, as we work with families, I can't stress to you how important y'all are to a family. I didn't have those resources during that time period and stuff because didn't know a lot. Because Caleb was at the mild moderate level, we couldn't have any services really other than CRS for testing his hearing and getting the hearing aids and following up every year. There was no academic help that we could get because he fell in that gap where they don't do the IEPs at that time, and so we just kept struggling and went through the hearing aids, and his classmates were wonderful. It's really amazing when you do a lot of teaching how children can adjust their behaviors and adjust how they treat other children. I went to school that day with the teacher's permission. We went through Caleb's hearing aids, what they do, why they do what they do, and the children just adjusted, and they worked with Caleb, and they helped, because fortunately Caleb was in a small school setting in private school, and we only had 18 children in the class, so they just loved Caleb for who Caleb was. But the social factors came later on, and it came mostly from the adults, the teachers, not adjusting. Fourth grade came along, and we got to the point where we didn't need to wear hearing aids all the time, and so we teachers, you know, every year go to school and you sit there and you tell them what Caleb's needs are and how they need to help him and not turn his back to him and not do this. And sure enough, we went through the school and had educational testing done and things, and found out that the teacher had Caleb's back to her at all times. So Caleb was not progressing. He couldn't learn, even though he wasn't wearing his hearing aids. What we found out that because Caleb had a eustachian tube problem, that depending on allergy season, ear infections, sinus trouble, that was blocking his hearing, and so therefore he had what I called variable hearing loss. You know, it was times where it was greater than other times. And so we went through all those things, but you know, we got through that, we adjusted, we told the teachers no, we weren't going to do medicine for ADHD because the symptoms mimic really close. And so the parents didn't know. I mean, if I hadn't been a nurse, the parents would have had him on medication and stuff when it was actually his hearing that needed to be addressed. And so his doctor asked me when he got in junior high school, the teachers were all upset because of Caleb's spelling issues and stuff, and he looked at me and he says, "Mama, technology is such that spell check is on everything. And so you need to choose what your battle's going to be because this is a lifelong thing." So this isn't just for infants now that we have this ability to test and know early, but these children are in a lifelong lesson. They're in a lifelong social issue, getting along with other children, getting along with teachers at school. They think children like this are, discipline problems or issues and stuff. And Matt Caleb is the sweetest child. I have to say, I have 5, and he is the sweetest because he's just so, loving and kind and sweet-spirited. And, I just didn't see what they were seeing at school and everything. And so I told my husband, the doctor's right. I'm just not going to worry about it. And once we gave that up and we quit worrying about it, summers were very difficult. The kids may need to go to summer school all year round to keep up and to keep going in their class studies. So that parents may need help with that. And, we did it, and we just accepted it. And I told Caleb, oh, well, it's fine. Now you know your summer plans. We're not going to worry about grades. We're not going to argue. We're not going to fight over it. We're just going to deal with it. And so his last 2 years of high school, he did great. He actually, in 5th grade, we at that point had to do titanium tubes for permanent tube placement because of the frequent infections and fluid buildup of the drainage. And actually the doctor, when he opened up to do them, found calcified material behind his eardrum and everything. So that was therefore increasing our blockage and our issues and everything because the eustachian tube couldn't drain. And so he removed those. We put the permanent titanium tubes. We just removed them his senior year and got the award for wearing them the longest in the doctor's office. And Caleb now has normal hearing with a few decibel issues at lower certain decibel levels, but not major. And so he's completed his first year of college and only had like 1 C, which I think is pretty good. And he's always been my awesome attitude of he wanted to do great and mighty things, His first goal was to become the zookeeper at the Australian Zoo, and that's kind of changed. He's made our home into the Australian Zoo of farm animals now. But it's just really so hard for the children to progress. I loved how some children accepted Caleb. Caleb was very short in stature, and one of the kids that was a grade above him playing pee-wee football was 6 foot already at that age. And if Caleb didn't hear the coach's call to play, he just picked him up and plopped him over into the position he needed to be in, and they played ball, and Caleb was he was so fantastic as a football player. He was a 150-pound nose guard and won all kinds of awards and stuff and did really great. But I say all of this to say where you as care coordinators can just help these families. There are so many different needs that you don't think about when you're walking this path. Now that I look back and, I'm just so thankful to be in this role and be able to help you guys. So I am available. All of us are available in our department all the time if you need us. But it's so good because now I have somewhere to go with my soapbox that I've had for 20 years, dealing with all of this and everything. But it is just really so good that y'all can get in there and help. You can help the families. There's so many issues. There's social issues that they don't know how to deal with. It was only through lots of grief and issues and conversations that we made it as a family. And you can just reach in and help by setting up these appointments. I didn't know where to turn sometimes, because everybody wanted my child diagnosed as ADHD, but I knew he wasn't, and I didn't know how to deal with that and how to go with it. So those are a lot of social and issues that hearing families face. Sometimes you think it's fortunate that, you know exactly how bad your baby's hearing loss is. But, over time as they grow, their hearing can change. And so it's important to make sure that we're okay and not a misunderstood group of people, which, you know, deaf and hearing loss has been a common mistaken group of people over the years and stuff. I've come to learn to know an older man who has dealt with it all of his life, and learn how that was back in the day before we had all of you guys and all these things in place to help these families and stuff. And so just really thankful to be here and grateful to share my story, and you know, because it is a long, hard walk for families, even though you finally get a normal diagnosis.
Marianne, let me ask you, was it your experience, if you have a child who has a hearing diagnosis, do they normally go in each year and test and retest to see has there been a change, or how does that happen?
Yes, they do. If, you know, like we came out of CRS once they determined that he was at a normal hearing loss and didn't need his, you know, hearing aids anymore. So we came out of CRS and was kind of a little lost there for a year or two of not knowing, because Caleb did good for a while and everything. But then when those allergies and all those things started back and we started having trouble again, then we had to go back to our ENT doctor and everything, and he followed him very closely, and that's who did his tubes and stuff. And then as Caleb got a little older and started having a little more difficulties in school, we went back through CRS. One of the teachers came up to the plate and referred him back through CRS and went back through it, and said they kept monitoring every year and everything. And actually he'll still go back, even though he's 20, he'll go back this fall for one more test to make sure that the decibel level has not changed or anything. So.
Well, I think now we're to the point where we're going to talk about ACORN and the changes that we're going to be seeing. So we are really excited. We've been working on this report to referring provider for over a year.
It's been a very long process. It got put on hold because of the EHR, the impending EHR. So it was one of those things, why put something in ACORN if the EHR is just going to come right along? But since with the delays in the EHR, and we just kept seeing some issues in the records, and we're hoping that through this new report to referring provider, it's going to walk you through more of what the requirements are for protocol, so that we won't continue to keep having to email you and say, hey, we need you to double check on this record. So we're hoping that this is going to make it a little bit more concise. And the other piece of the puzzle is it's going to get newborn screening what they need. So since, and remember, newborn screening referrals are carved out of the RCO, so we will continue with these referrals. So we want to do everything we can to make sure that we're working right alongside with the newborn screening staff and getting them what they need. So I'm going to turn it back over to Melissa, and she's going to walk us through the changes.
And like we were talking about, the changes have been made to the format just to really help guide you when a case needs to be open, needs to be closed, and just to help the families meet their child's needs. The new format should benefit every care coordinator who comes into contact with a newborn hearing referral. It is particularly going to benefit those care coordinators who frequently, or who on occasion actually get actually get a newborn hearing referral. The good news at this point, there are no changes to the protocol, but I am saying at this point, because as this has progressed today, I see there are some impending changes. But right now, we do not have any changes. The care coordinator should only notice a new format for the report to referring provider in the ACORN system. Okay, before we get into the actual format changes that we're going to have, I want to just review the electronic referral process in ACORN. What happens, we receive the referral through CCRS. We enter the electronic referral information in ACORN. And when entering the information, in what we normally do, y'all will put Dolores Harrison's name in there, or we used to put Saracia Johnson. It's perfectly fine. You can just put newborn screening program in as the referral source and include the correct fax number. But that way you don't have to remember who's the person, you know, which name and this and that. If there's a staffing change, this takes care of that. And we are hoping that we will be able to change that information in CCRS, because I know many of you cut and paste the information from the referral out of CCRS. So that is one of those changes that we are requesting as well. You're going to go in, you're going to complete each of the tabs on the referral page based upon the referral information that's received. You're going to complete the patient information section, the referring provider, the reason for referral, the psychosocial additional information, and of course your name will pop in there, that very last tab, and you have to make sure your phone number's right. No changes have actually been made in ACORN to the referral form at this point. I wanted to show you, and let me just mention, many of you, if you're viewing today, many of you probably printed out the handouts. And what the studio had to do was, there are two different handouts, and so you will see, because you may not be able to actually view these images on the screen as well today, so if you will, you want to definitely refer to your handouts. But this is just the referral source tab, and you, of course, you're going to choose your program, which is Patient First Children at this point in time, and referred by, and this is where you're going to put in your newborn hearing screening program, and you want to have your fax number listed there as well. And this just walks us through it. We're going to do Patient First. Central Office is our referral source, and the newborn screening information. When completing the Reason for Referral tab, you want to select newborn hearing in the medical conditions. That is extremely important. You want to select medical condition. Don't just select hearing loss, but select medical condition as well. And you want to enter the lab number.
And the reason why you don't want to select hearing loss is because we don't know that yet. All this referral is that the infant did not pass the newborn hearing screen in the hospital. We don't know if they have a hearing loss yet. So that's why we don't want you selecting hearing loss in that medical condition tab.
And this is just a screenshot of the Reason for Referral tab. And just when we have some new staff across the state, so I really felt like it was important for us to go through, not only for review purposes, but for our new staff who have not been through training yet, our Reason for Referral tab. And this is where you'll see your drop down is there. There may be other reasons in that list that you need to select, and that's perfectly fine. But you just want to make sure that you've got the newborn hearing loss selected as your medical condition, and then the lab number. I would like to say just a brief statement about the lab number. Most of you may already realize this, but it's an 11-digit number, and it is required in ACORN. If you do not have that lab number, typically it comes over in the referral information from CCRS. But if you don't have that lab number, you can contact Diane or me in the central office, and we'll be happy to get that for you, or newborn screening, and they can provide that information as well. But that is just critical information because the screening results, I guess, come over as a lab number. All right. And I want to just talk a little bit about what's the big deal about the electronic referral screens in ACORN. The big deal is that ACORN chooses the report to referring provider format based upon the referral source or the referred by information. So, for example, if I'm entering my electronic referral and it's a newborn hearing, but then I choose PMP, well, the format that you're going to get to do your actual report to referring provider is not going to be the information that Rachel and her folks need. So the second thing is that, and it's probably pretty important to most of the staff out there, is that the total number of referrals for each county and public health area are calculated based upon the number of electronic referrals entered in ACORN. So basically what that means is that you might get, an area might get 500 newborn hearing referrals, but if you only enter 300, that's all the credit you're going to get is 300. So it's just extremely important that you make sure that you enter those electronic referrals accurately, and that information is in there, because we want you all to get the credit that you need. And I'm assuming that staffing is done according to the numbers of referrals. Part of the staffing formula would be the amount of work. So if you don't have the information in there, I don't think that Meredith would be able to advocate for you to get staff. So it's just extremely important. I just want to say that coming soon, we're going to have a new newborn hearing report to referring provider. It's new, it's improved, it's user-friendly, and what I like about it is practice and protocol driven. This is a very difficult protocol because there's so many different things that can happen and different diagnoses and different situations, and you're not sure. we tried to develop a form that was going to really guide you and help you in making those decisions, so you didn't have to do as much thinking about what does the protocol say. We want you to be able to concentrate on doing that good social work practice, and because that's what we're here. We're here to do good practice and help our families and help these children to develop normally. So we're just really excited about it. The document guides the care coordinator through the protocol as the report is being completed. Questions are going to populate based on the responses chosen by the care coordinator. Completing the report to referring provider, we're going to, what you do is you go in, and most all of you know, you're going to select Create Report to Referring Provider, which is there in the, you'll see from the graphic there, Create Report to Referring Provider. All the information that you've submitted from your electronic referral is going to populate over into that form. So, again, if you've chosen Medicaid, then Medicaid's information is going to go over there. So you're going to create that report to referring provider. What we've done is we've gone in and we have, because our protocol requires that delivering hospital contact, our first step when we get a newborn hearing referral is we ask the question, was there a second, we ask that question to ourselves, or at least I do, was there a second hearing screen done in the hospital prior to discharge? So that's the very first step. I need to call the hospital and ask that question, did they do a second hearing screen prior to discharge? So that's why it's very important. We're going to make sure we're calling the hospital. You're going to review the additional information section of CCRS and determine what do you need to know. You're going to verify the Medicaid status. You're going to, like I said, contact the hospital. And if you contact the hospital and you find out, hey, the child passed the hearing screen in the hospital, they don't have hearing loss, you're ready to submit a report to the referring provider for newborn screening. That's the easiest kind of newborn hearing referral anybody can get, I think. So here's a scenario that we've come up with, and with our scenario, then I'm going to complete the report to referring provider, or show you some screens that will show you how to do that. So what you're doing is that the scenario is the ADPH Care Coordinator receives a newborn hearing referral on the infant rolling tide. The care coordinator makes a follow-up call to Druid City Hospital where the child was born. So we have rolling, and she was born on 6/24, and Crimson in white, she is the hospital staff nurse. Well, Melissa, the care coordinator, calls, and I talk to Crimson, and she tells me, yes, that Rolling Tide was rescreened on 6/28 and passed. It was an ABR was done, an AABR was done, and passed prior to discharge in both ears. So, I mean, this is a fantastic case, not only because of the child's name, but also because the child has passed the hearing screen in both ears, and the parents are not going to have to worry about any follow-up appointments related to the hearing screen. So this is what you're going to do. You create your referral, you go in and you select summary. Then you see delivering hospital contact. I want to just highlight before I move into more specifics. You'll see on this screen we have our contact types. There are delivering hospital contact, repeat hearing screen, diagnostic testing, and referred for early intervention services. I previously made the statement about the information is going to auto-populate based upon your answers. So this is what I'm talking about. When the different report types that you choose here, different questions are going to pop up. So in the scenario that with Rolling Tide, we said this was a delivering hospital contact. So what we want to do is we want to select delivering hospital contact. We complete all the questions on the report. No additional information is needed, and we select Send Report to Referring Provider. Okay, so with this particular report, we've gone in, and you'll see there's a selection for the provider. Druid City Hospital would be our provider there, and then the city of the provider, Tuscaloosa, and then we want the date that it was done. The AABR would be chosen as the method, And then there's 2 questions that pop up in regard to right ear and left ear, pass and pass for Crimson, for rolling. And if there was some, let's say that Crimson in white, the nurse, happened to mention to you while you were talking to her that there was some other issue going on, you could use the additional information box, and on the graphic there's one, it's highlighted in yellow. This box is no longer required, or will no longer be required. And so if there was something that Crimson happened to mention, like for example, if she said, yes, there are risk factors, this would be a fantastic place for you to put that information about risk factors, so when you submit that report to a referring provider, Severity will have that information. So once you've submitted that, you are through, you have finished with this case, and it's ready for closure. You just want to make sure that there are no additional needs that are noted before you actually close that case, but that's, to me, one of the easiest types of referrals. Now, what happens when the patient does not pass the hospital newborn screening exam? And so let's talk about completing that report to a referring provider. So the scenario is that you contacted the hospital, you found out that they did not pass the hearing screen that was done there, and they have actually set up an appointment, because that's what's supposed to happen. I'm not saying that it happens 100% of the time, and newborn screening will tell you that also. What's supposed to happen according to Joint Commission standards is the hospital who actually does the screening will go in and set up that appointment. So what you should be receiving, the information you would receive from the delivering hospital, they should be telling you, yes, rolling did not pass in both ears. She was refer failed. We did the AABR, and we have set an appointment up for 7/14. And then you're going to get a question about, will the patient's case remain open for care coordination services? Yes. That's your answer. You're going to put yes. If you choose no, you're going to get a little pop-up box, and I'm going to show you a graphic on that. You're going to get a little pop-up box that says, reminding you that you can't close the case until you actually have a final diagnosis.
But the pop-up box doesn't keep them from closing, though, right?
That's correct, Meredith. The pop-up box does not keep you from closing. It's just one of those reminders, and I think it would be so helpful for new employees, and just a reminder about what the protocol is. So you would always, in this situation again, the patient did not pass the newborn hearing screen prior to discharge. You complete every section there, and then you will enter that, yes, you're going to keep following the case. Okay. So here we have a case scenario that's referred for a repeat hearing screen, and Jefferson County Care Coordinator, she received a newborn hearing referral on Cindy Lou Who, and she reviews the referral information and completes the information. Okay. We're going to, and that's when I was just previously talking, had shown y'all a graphic with that, where you're going to go in and you're going to put your delivering hospital contact information and the city. And why is that information important? Some of you may wonder. That information is important for newborn screening. They need to know who to contact, and I think for stats and that type thing, that's why it's critical that they get that information. I want to talk a little bit about the care coordinator's role. We're there to help the family. We're going to assist the family in scheduling and arranging transportation for the repeat hearing screen. We're going to maintain contact with the patient and the family and the providers needed. We're going to continue to assess the patient's family's needs throughout the life of the case. We're going to remind them about the importance of attending these appointments and staying on top of them and just doing anything we can to help reduce the barriers that may be preventing the parents from getting their child to the doctor. We're going to educate the family about the importance of following through with those appointments, and we're going to link them to any needed resources or services. And that was just a real brief list of the things that that care coordinators, social workers would be doing, but I'm sure there are many other things that are done as well. So please don't consider that list to be all inclusive. So here are patients referred for the repeat hearing screen. We've got all of our updated information, and the care coordinator is ready to submit an updated report to newborn hearing. All right, so this is we have repeat hearing screen. that's our screening type. Was the patient referred? Was the referred patient scheduled for a repeat hearing screen? Yes. That's. Then the next question is, was a successful contact made with the patient? Did the patient accept services? Did the patient keep the appointment for the repeat hearing screen? Now, I have some graphics in here you'll see as your answers change, the questions change. So this is repeat hearing screen. This is what it's going to look like for a repeat hearing screen and your appointment is kept. Okay, you go in, you've got your repeat hearing screen. The question about the appointment is kept, yes. Then you're going to put in the appointment date, okay, and then you would continue to complete the rest of the information, the testing method, the results, and the provider information, and then also are you going to keep the case open. So that's an appointment kept. Now, this is a missed appointment for repeat hearing screen. Okay, so we're going to select our screening type, and then we're going to go in and we will see that you get the question of, did the patient keep the appointment? No. Then there's a question of, well, what efforts did you try to make? If you were unable to locate the patient, for example, then there's going to be a question about what efforts you tried to make in order to locate the patient. Let's say that their cell phone was disconnected, or you made 5 home visits. There are some different choices here that you will be able to put in. And then what was the reason for missing the appointment? We've got some reasons that are listed here, and you would go ahead and choose that information. We are thinking that in trying to identify barriers that are keeping people from attending these screening appointments, this is going to be a great opportunity for us to be able to capture information regionally about what the reasons are. It's also, one of the choices here is, was the appointment missed due to the provider requesting that? Sometimes our providers' offices, their machines or equipment may not be working correctly. This is going to give newborn screening information that they need if they see a particular region in which a provider is there's a pattern of rescheduling appointments due to equipment. Then newborn screening can possibly help in buying equipment for that doctor's office if needed. So you want to go in and you want to enter that information in, and with a repeat hearing screen, if they've missed it, well, you got to get that appointment rescheduled. So you're going to talk to the doctor's office and find out, hey, did they reschedule the appointment? What's the rescheduling date? Maybe you got that information from the parent. Yes, we had to reschedule because I had the flu. Well, if you get it from the parent, you're calling the doctor's office to confirm that. You're going to complete the information in regard to when the appointment is, and if there's any additional information that is needed, and of course you're going to continue to follow the case. And again, the additional information section is no longer required, so you don't have to put anything there. If all the information, one of the things about this report, we have given everything, we think, to newborn screening that they need. So they don't need any other information related to diagnosis, appointment dates, that type thing. Nothing. They don't need anything else cut and pasted from your notes, unless it's something, out of the ordinary. That's what you'd want to include there. Okay. So if they didn't pass, you're going to go through the top portion there, and then you're going to select Refer, Fail, and you're going to include, and this was the example of the Jefferson County case, I think, that I just mentioned earlier. The Birmingham Audiology Group, you want to put that information in there, and then the telephone number, and that you're going to continue to follow the case. So what happens? The referred infant does not pass the newborn hearing screen and is referred for diagnostic testing. This is, to me, I think it's going to simplify things so much and just make it so much easier for our care coordination staff. So how are you going to complete that report to referring provider? I'm going to give a little example of just a diagnostic testing. The care coordinator learns from the hearing provider that they didn't pass the repeat hearing screen. They've scheduled for a diagnostic appointment at Children's. And the provider also mentions that the mom seems a little bit concerned about transportation issues. She lives over in Walker County, and she doesn't have a reliable car. And so she's telling the doctor's office, I'm going to do my best to try to get to Children's, but, you know, I don't like driving in that city traffic. So, because she lives in rural Walker County, so that's, to me, if I hear that from a doctor's office, that's some pretty important information that I want to make sure when I'm calling that mom, I want to say, hey, can you get there? So, again, our role there is we want to maintain contact with the patient and the family, and we want to make sure that they have a way to get to the appointment. And we want to assist them with arranging transportation. You know, it could be in this Jefferson County case, it could be that mom needs help with kid 1. This is her first baby. She's never known about it. And she's all freaked out because her child may have hearing loss, and she's got to go to Children's Hospital. So I try to put when I work with families, I try to put myself in their shoes and just think about the many things that they're having to go through. And so, yes, how important an appointment reminder is. Just picking up that phone and calling that parent because they are dealing with so much. We're going to link that family to needed services. So we're ready to do our report to referring provider, okay, for, let's say they've missed the appointment for diagnostic testing. Mom couldn't get there. Something happened and kid 1 was not able to pick her up, and so she couldn't get there. So this is what happens. We're going to select diagnostic testing as our screening type. And did the patient keep the appointment? Well, let me back up. The other questions are just the same. Was the patient referred for a repeat hearing screen and was successful contact made? Did the patient accept services? You will find that question on every report to referring provider, because if the patient doesn't accept services, then we have another issue and we'll discuss that a little bit. But that question is on there as well. And then, did the patient keep the appointment? No. Then your questions are going to come in, your choices are going to come in of the reason why the patient didn't keep the appointment. So was the patient rescheduled for another diagnostic hearing testing appointment? Yes, that's going to be what you choose, yes. And when you choose yes, date of scheduled diagnostic testing is going to, that question is going to come there. And then there'll be a drop-down box for you to actually choose your date. And then the question of, will the patient's case remain open for care coordination services? If you choose no, then you probably will definitely want to explain why. Let's say if the parents move to another state. You've chosen up here in this section of what was the reason for not attending the appointment. If the parents have relocated to another state, that tells Seracia and other folks in newborn screening that there's not going to be a follow-up appointment in the state for diagnostic testing. Then newborn screening will know if they need to contact Georgia to give them some information, and they will have what they need. If you happen to have the updated address of the patient of where they're moving, that would be great information to put in the additional information section. So our appointment is kept for diagnostic testing. We go in, we choose diagnostic testing. Did the referred patient have a repeat hearing screen or diagnostic testing? Yes. And was contact made with the patient? Yes. You would choose that. Did the patient accept services? Yes. And then did the patient keep the appointment? Yes. So we've gone in and the patient's kept the appointment. You've talked with the hearing provider and you found out that they did the ABR, the AABR, and the child passed in both the right and the left ear. Because remember, for all repeat hearing screen diagnostic testing, we've got to have results for both ears. Then we passed in both ears, and then I'm putting my audiologist information there as well, and the contact information. And will the patient's case remain open? Everything's fine with this family. Life is great. Their child doesn't have hearing loss. There are no other services that are needed, so you're going to get to close the case. You would complete that report and submit to report to referring provider. So the appointment is kept. Here's diagnostic testing. The appointment is kept, and the hearing loss is detected. So this is what you'll want to do. You've got your referral, and you've gone in and you've created a new report to referring provider, and this is going to be your scenario. And so you select diagnostic testing. Then you go through, and was the child referred for diagnostic testing? Yes. And then you will continue to answer those questions. Was the appointment kept for diagnostic testing? Yes. And you're going to put your method, and here they were referred/failed. And then from there, normally what happens next, you've got your provider information, then you get a diagnosis. So this is, to me, one of the coolest parts. So because you've indicated the child has a diagnosis, you will actually, the required information that newborn screening needs is going to pop in there. And it will ask you questions. Type of hearing loss in the left ear. Type of hearing loss in the right ear. And that would be normal, conductive, or sensorineural would be your choices. So you choose one of those three. Then there's severity of hearing loss. Mild, moderate, and I cannot read the
Profound.
third. Profound. And so you would choose those. And then you would go in and complete your diagnosis. And here we are. This child is, the hearing loss is detected. And so you would submit that report to a referring provider.
May I interject something very
Yes.
quickly? It kind of ties in with what I was talking about earlier when you talk about the severity of hearing loss. If you have a baby, which you typically see a lot of times, where they have a hearing loss range, when you select the severity of the hearing loss by bubbling in, you always want to choose the one that is the most severe in the range. This would be one where it would help us to have some notes so we would know, again, if they said mild to moderate, you may select moderate where you bubbled in, but if you put mild to moderate in the notes, then we would have more accurate information from that report.
Okay. You just brought up a very good point that I had not thought about. So if when you're talking to the ENT and they say, yes, the child was diagnosed with mild to moderate hearing loss, well, on the report, that's not an option. We don't have an option for mild to moderate. And I believe, and I'll have to double check it, but I don't think you can select both mild and moderate on the same ear. So what Saracia was just telling us was if it's mild to moderate, then you need to bubble in the most severe. So that would be moderate. So if you can only choose one thing on that ear, you're going to go with moderate if they give you a range. Go with the most severe. So that would, in a mild to moderate instance, you're going to pick moderate on that.
And so in this scenario, that question of will the patient's case remain open for care coordination services, that is critical. Yes, the case is going to remain open because our next step is going to be referred for early intervention services. We don't want to leave our families out there hanging or floundering trying to figure out what they're supposed to do. So what our protocol, the way it's set up, is we're there to help guide the family till they actually get into early intervention services. So the care coordinator learns, here's the scenario, the care coordinator learns from the audiologist the referred infant was diagnosed with hearing loss and was referred to early intervention services. Okay, and so again, the care coordinator's role in these cases really is to be there for the family, assist them with getting to the appointment, whether it's reminding them, assisting them with transportation if they need, if they're having financial problems and they're on Medicaid and they need assistance with accessing Medicaid transportation services or reimbursement for that, then you want to walk them through that. And you want to be support for the family. You want to assess every interaction that you have with that family. You want to continue to assess the patient's needs because in this scenario, the family has just found out their child has hearing loss. That's pretty huge. And I have a child, so I don't even know how I would feel. I would feel devastated, I think, initially. And because it would be so foreign to me. But I know there's so many resources and services that are out there for our children who have hearing loss. As a care coordinator, what we want to do is I think we really want to support them and we really want to motivate them as much as we possibly can about accessing services, increasing their desire to become more educated about hearing loss and teaching them how to advocate for their child who has been diagnosed with a hearing loss. So it's a pretty big job that care coordinators have, so don't ever minimize what your job is because it is huge. So here we are. We're referring for early intervention services. And so you go in, you create your report to referring provider, and your screening type that you're going to select is referred for early intervention services. Then the questions will come up. Was the patient referred for early intervention services? Yes. Was there successful contact made with the patient? Now, if I say no, then that question is going to pop in of what were your efforts? Did the patient accept services? Yes. And who is the patient's EIS provider? And you will see you're going to have AIDB, CRS, or other. So you choose one of those. If you choose other, there's going to be a text box for you to actually do some free text there. But primarily AIDB and CRS are our choices in Alabama. And did the patient keep the appointment with the EIS provider? Yes. And remember, this additional information box is not required, but it will be there if you want to share any information. Okay, so the appointment was kept. All right, so here we're referred for early intervention. And was successful contact made? Yes. Did the patient accept services? Yes. Remember that question about who was the provider, AIDB or CRS or other? If you, in this case, my example is AIDB. Well, what happens below, the next thing that populates there is you're going to see all the AIDB centers throughout Alabama, and you would choose the one that's applicable to you or to the referral. CRS, if you choose CRS, then you're going to have all the CRS sites that will show up there. And then, did the patient keep the appointment with the EIS provider? Yes, you're going to include your appointment date there as well. And one of the questions that will appear here is because you've chosen yes, the question comes up, did the care coordinator confirm with the EIS provider that the patient attended the initial appointment? And sometimes our patients are not, they have a lot going on sometimes, and they think they attended the appointment, but they got it confused with another appointment. So you always want to confirm with EIS, your early intervention provider, did they attend the appointment. And when you're talking to Jane Smith at EIS, that's the opportunity. Did y'all open the case? And Jane Smith says, no, we weren't able to because the patient does not qualify right now for services. That's when that next question is important about, are you going to keep the case open? Well, that answer that Jane Smith at the EIS resource, they're not actually opening the case yet. So we're going to continue to follow that. And we're going to I would put in my additional comments of why, because per the nurse, they need to have another evaluation, and it's set for 2 weeks from now. So that, to me, is critical information that newborn screening would need. With a missed appointment for early intervention services, you will see you're going to select referred for early intervention services, and you would go through and answer the questions, and then, but the question of did the patient keep the appointment? No, she did not, and you would select your reason why, and of course here are all of our center sites on this, the EIS sites as well. And then if I tried to close that case, here the patient has missed the appointment, and on this graphic you'll actually see the pop-up box that comes up, just reminding you that you cannot close the case until there's a final diagnosis and until early intervention services have actually begun. So I'm going to just talk briefly about when to, just as a reminder, when to submit the report to the referring provider, and that needs to be done within 30 calendar days of opening the referral. We want to also submit a report to a referring provider when something of significance occurs in the case. Let's say, for example, that the screening results received, the appointments were rescheduled, and an infant was diagnosed with hearing loss, unable to locate the case, and you've had to refer the case to a local DHR. That's pretty critical information that newborn screening needs. And upon case closure of referral due to the patient's goals being achieved. And just wanted to also talk just briefly and remind, I know Severity had talked about this with our goals in regard to care coordination services for the newborn hearing population. Our goal is to ensure that children with hearing loss are diagnosed within 3 months of age 1, 3, and 6, I think, those are my new numbers to make sure that I know. I think about care coordinators and tickler systems, and people are trying to develop how they're going to remember. And I think about, okay, 1, 3, and 6. If I was getting a case, how am I going to put that 1, 3, and 6 for that child in my tickler system? And how am I going to help that family to ingrain that 1, 3, and 6 in their thinking, so they can get that screening done. We want to assist the newborn and the family with getting all hearing or other developmental screenings completed. And we want to notify newborn screening of the results of any pertinent information that we might receive. And just case closure reminder, although the system is going to be there to help guide you through when it's appropriate to close a case or when it needs to be closed, it's not going to prevent you. Yes, you will still be able to close a case even if you haven't followed protocol. It's not going to stop you from closing the case. So that's why I feel like it was really important for me just to remind you that with a repeat hearing screen, in order to close that case, you've got to have a pass in both the right and the left ear. Diagnostic testing, you must pass both ears, have a final diagnosis, and since we've made it a lot easier, you'll just be able to bubble in what those diagnoses are and the severity and the type. You would put that information in and submit your report, and then you want to definitely refer, when they're referred to early intervention, infant must pass in both ears or have a final diagnosis and testing method used and an initial appointment with CRS to open their case. That's your really the brief guidelines of when you can close a case. I know everyone's going to be eager to start this new format because we've just been eager for it to begin as well. We are not sure. IT has been working on this. We are hoping by the next, 30 to 60 days, but I'm hoping it's more in the next month or so, we will have these edits made in the system. We've gone through and we've done lots of testing on what IT has done, and it really looks great. But we are hoping as soon as we know what we're going to do is we're going to get that information out to the county staff so y'all can be preparing. And we are not requiring that this training be done, but we are really encouraging that if your coworker, for example, is not viewing it today, on down the road, you might want to mention, hey, you probably want to watch that because it's got all the changes in ACORN that's coming up. We are going to require this for any new employee, this particular training for any new employee who is coming on board prior to them coming to patient first training here at the central office. And I think are there any questions?
Well, I just wanted to mention, Melissa had talked about there's different tabs. Well, it's not exactly a tab, but there's different bubbles at the top that you'll select for which is it the delivering hospital contact, the hearing screen, or the diagnostic testing, or the early intervention. I wanted to go over with you how does that work exactly? Like, do you go into the current report to referring provider? No. You're going to create a report each time. So each time that you're doing a new contact, you're going to want to select Create Report to Referring Provider and start a new form. So there's going to be multiple forms in ACORN for us to go back and look at that'll take us through that entire process. So we've got a couple more minutes. Please feel free to call or email us, and we're happy to take your questions at this time.
And I was just to piggyback on something that Meredith said, you want to make sure you don't go in and edit the previous report that was submitted. You want to create, and she was saying that, but I just felt like I need to say don't edit the one, because I know that at times that we've seen that.
And while we're waiting for questions, I just want to thank the newborn screening staff again. Mary Ellen, I really enjoyed your story. Thank you for telling us about Caleb. It's really good. I always think that when we have personal stories, it seems to add to the training aspect a lot better, and it gives you that more human element that there are actually people out there with hearing loss that we will be dealing with. So I appreciate your time in doing that today. Thank you. And also to Rachel and to Sureisha. I know from Sureisha's presentation, I learned a lot. The AABR and the ABR is definitely something I am taking away from training today that I understand a lot better now, which is good. So I want to thank y'all both for your time today. So thank you for that. We still have time. If you have any questions, please do not hesitate to call or email us. We are happy to take those. We will send you out an email and let you know when the edits in ACORN are going live. I'm sure some of you are aware that we were having some CCRS issues. Well, those kind of took precedent over these changes, and that was part of the delay. And when we roll it out, we want to make sure that it's working properly. And in our last testing phase, there were a couple more tweaks that we wanted to make sure that it was working the way that we needed it to. So we don't want to put something out there unless it's working right. So that's part of the delay in it going out. But we're hoping that once it can jump back up in the priority list after some of our CCRS issues, that we can go ahead and get this rolled out to you as soon as we can. We will send you an email and let you know. I think it's really important that if you are working newborn screening referrals, you need to view the training. So I'll be in touch with the area social work directors and let you know when this is coming out live so that you can have staff go ahead and view the training so that they're prepared when they get a newborn screening referral. So at this time, we still don't have any questions or calls.
And I was going to give a reminder, too. So after you've submitted your report, which, when you submit your report, you're actually sending a link to newborn screening. When you actually submit that, if you happen to have, just a reminder, if you happen to have that written report, please fax that in to newborn screening. And when this rolls out, and as you're doing this, doing this new form, if there's any suggestions or feedback that you have in regard to changes that need to be made, or please contact me, email us, Meredith, and let us know, hey, maybe I ought to do it, maybe you thought about doing it this way, or if we need to reword a question, please give us your feedback, because that's vital for us to continue to improve our process throughout the state, is to have that feedback from the county staff who are actually out there doing the work every day. And we want to make sure that everyone, that the forms that you're completing and the information that you're having to submit, that you understand why you're doing it and what information is needed.
Well, at this time, we don't have any questions and we don't have any calls coming in, so I want to thank you for joining us today. And once we roll this out, if you have any questions, concerns, or issues, please do not hesitate to call or email us at any time, and we're happy to help with that. Thank you again for everything you do every day, and have a great day.